Ladies and gentlemen, thank you for standing by. Welcome to the Arrhythmias and Sudden Death in Myocarditis webinar. During the presentation, all participants will be in a listen-only mode. Afterwards, we will conduct a question-and-answer session. At that time, all participants on the phone lines, your lines will be open and interactive. If you would like to ask a question during the presentation, please use the chat feature located in the lower left corner of your screen. If at any time you need any operator assistance, please press the star followed by the 0. As a reminder, this conference is being recorded Monday, November 8, 2010. It is now my pleasure to turn the conference over to Ms. Candace Moose, Executive Director. Please go ahead.
Welcome everyone to our, third webinar produced by the Myocarditis Foundation. Today's topic is Arrhythmias and Sudden Death in Myocarditis. And our presenter, we are very blessed again to have Dr. Leslie Cooper, Professor of Medicine at the Mayo Clinic in Rochester, Minnesota, and also the founding President of the Board of Directors of the Myocarditis Foundation. Welcome everyone. One note, a reminder that the muted portion, the slides of today's webinar, will be posted on the Myocarditis Foundation website for you to review at a later time, at any time actually, in another several days. So at this time, without further ado, I would like to turn the presentation over to Dr. Leslie Cooper. Dr. Cooper.
Thank you, Candace, and I'd like to thank everyone who's participating in the webinar today for calling in or dialing in. My goal today is in the next 20 minutes or so to give a broad overview of the role of arrhythmias and their role in causing sudden death in patients who have acute myocarditis, and how that risk extends into the future after acute myocarditis when people have a dilated cardiomyopathy. Many people have been affected by myocarditis through loss of a loved one or family member or friend, and this is one of the least appreciated but most important impacts of myocarditis worldwide. The first slide is not coming up. There it is. The myocarditis is the third leading cause of sudden death in people under age 40. There have been 8 or 9 autopsy studies which looked at people who died of sudden death, and they consistently show that after congenital coronary anomalies and hypertrophic cardiomyopathy, that myocarditis is responsible for between 5 and 20% of sudden death. And as you can imagine, most of these patients have no symptoms. Some have a upper respiratory tract illness for a short period of time or a sense of malaise. But most people do not recover. They are not resuscitated unless they happen to be in a hospital or near to medical care, and it is just devastating. The mechanism of death can be either a fast heart rate, such as ventricular tachycardia, or in this example, a lack of ventricular response in this patient who had a sudden bradyarrhythmia. The clinical event is the same, with a sudden loss of consciousness. The risk of this occurring in viral myocarditis is fairly low, around 1%, but in certain types of myocarditis, such as giant cell myocarditis, the risk is much higher, on the order of 25 or even 30%. This is the sad case of a young girl who had a giant cell myocarditis and died, who underwent heart transplant, and the dark area of the heart on the inside is the region affected by myocarditis very severely in her case. People of all ages are affected, not only young people, but the risk appears to be greatest in people in their 20s, 30s, and 40s. Now, in patients who develop a clinical syndrome, either shortness of breath or chest pain following a viral illness, you can frequently diagnose myocarditis with non-invasive tests such as this, cardiac MRI, and you can appreciate the white arrows, which are pointing to the white regions inside the dark walls of the left ventricle. The central region, which is lighter, is the inside of the heart. It's the region in the vessel, in the muscle wall, which is brighter white, which reflects myocarditis in this image. And in patients who have recovered from either acute myocarditis with heart failure or from an arrhythmia with loss of consciousness after resuscitation, this is not an uncommon finding. And in people who have normal heart function, we don't know whether to recommend in these settings a defibrillator or not. The clinical meaning and significance and prognostic value of these white spots in the ventricle is an area of active investigation. Histologically, myocarditis has a variety of forms, and the form of myocarditis seen under a microscope is actually very important in prognosis. This image shows giant cell myocarditis, which is a rare but particularly severe form of the disease. In the very center of the image, you can appreciate blue nuclei and cells with a central region with lots of those blue spots, which are in the middle of a giant cell. And that is diagnostic of this kind of myocarditis, which, although uncommon, is almost universally fatal if it isn't treated with immunosuppressive therapy or heart transplantation. More common forms of myocarditis, histologically characterized by lymphocytes, little blue immune cells under the microscope, or macrophages, is generally much more benign, with only a risk of transplant of around 4.5% in the first year. There are new markers, which you can see in this image coming up in a moment, of connexin 43, abbreviated CX43, in patients who have a lot of arrhythmias, and that could be due to a variety of diseases, such as one is called arrhythmogenic right ventricular dysplasia, which is illustrated as ARVD in this slide, or giant cell myocarditis, or another disease called cardiac sarcoidosis. There's a lack of this protein, so in the top image you can see there are blue heart muscle cells, or myocytes, with little white vertical lines, and the white vertical lines are the connexin 43. And if you look down below at the lower image, you can see that there's no vertical white lines in the blue muscle cells, and that shows a lack of this protein, which is associated with ventricular tachycardia. This is one of the markers we hope will turn out to be useful in predicting who will develop ventricular arrhythmias and who might need an implantable defibrillator. In the next slide, you can see survival curves, and there are 4 curves in the 4 boxes, and these reflect the survival of patients with and without antibodies to a certain heart muscle protein called the beta-1 receptor. And in the top left box, where it says DCM, patients who did not have the antibody in the light gray line did fairly well over 10 years. By myocarditis standards, they had about a 4% annual risk of death of all cause, as opposed to those patients illustrated in the dark black line in the same box, where they had a much worse outcome. The same was true not only for all-cause death, but for death from cardiovascular causes, seen in the upper right panel. And the reason I show this slide is to illustrate that there are potentially blood tests which could help predict sudden death or progressive cardiomyopathy. This particular one is not clinically available in most centers, but it is, again, an area of active investigation. There are no gene studies at this point for most people that will predict either the development of myocarditis or the severity of myocarditis. But to summarize, we do have some knowledge of what predicts arrhythmias in myocarditis. In addition to the histologic types, which I mentioned, giant cell myocarditis and sarcoid, the overall amount of damage reflected in the amount of blood the heart pumps with each beat, or the ejection fraction, is a strong predictor of sudden death. certain autoantibodies, like the one I illustrated against the beta-1 receptor, and certain histologic features, such as the loss of connexin 43, are emerging markers of risk as well. So what do we do to treat this? Hang on a second. The first and most important thing, let me go back one slide, is to follow the guidelines, both in Europe and in North America. The relevant cardiovascular societies have published recently extensive, detailed guidelines on the management of patients who have arrhythmias and patients who have heart failure with associated arrhythmias. And these are all relevant to the treatment of patients with myocarditis. And that's what I recommend that practitioners worldwide follow, because they really are well thought out and they're evidence-based. And I'm going to review now in the next 5 or 6 minutes a few of those therapies. This is far from a comprehensive review, but I mean it to be primarily illustrative of typical medications that we would use to help decrease the risk of heart failure and arrhythmias. The next slide shows, well, I skipped one. Let me go back one more. Standard heart failure therapy we consider effective if there is a demonstration that it improves survival, improves quality of life, or reduces hospitalizations. And there are 3 classes of medication which are generally useful. The first are ACE inhibitors, here ACEI, which unfortunately are not used as often as they should be. Beta blockers, which work on a different pathway and also are underutilized. And finally, aldosterone inhibitors such as spironolactone, which in the setting of acute myocarditis can be quite useful. This slide, which you can see here, describes the results of the RAILS trial, which is now about 13 years old, but is still useful for the point of illustration. And you can see the yellow bars, which illustrate survival, or event rates, I should say, in patients treated with spironolactone in the trials versus placebo in the orange bars. And there was a reduction in total mortality, cardiac mortality, heart failure, and most importantly on the right, in sudden death in patients treated with spironolactone at a dose of 25 milligrams per day. All endpoints were positive, and this is what we would hope to find for all medications that we were using for heart failure or arrhythmias. Unfortunately, that's not always the case. We sometimes see a benefit in one area and no benefit in another. The next slide shows the results of a similar trial in a different class of medicine. This was an angiotensin receptor blocker, ARB, called candesartan. And in this study, the likelihood of cardiovascular death in orange, cardiovascular death or hospitalization in yellow, or heart failure hospitalization was all significantly reduced in 2,000 patients. This is, again, a medicine that is very useful in the treatment of acute myocarditis. Those are really my only 2 slides on medicines. There are many others which we consider using in specific scenarios. This slide illustrates the effect of an implantable defibrillator in patients, some of whom had ischemic and some of whom had non-ischemic dilated cardiomyopathy. In the latter group, the non-ischemics are not infrequently the consequence of previous myocarditis. And in that group, you can see illustrated survival after treatment with an implantable defibrillator in green. And on both the left and on the right, survival was improved in patients who were treated with an defibrillator if their ejection fractions were less than about 30%. And that is our current recommendation for patients with myocarditis who do not improve within 6 months, that they have an implantable defibrillator, which is currently recommended in the guidelines. We do not recommend implantable defibrillators in people who have cardiomyopathy from myocarditis unless they've been given an adequate trial of medical therapy. Now, I skipped a slide, so hang on just a minute. There. So this slide is meant to give you all a sense of what the benefit is over the last 20 years of adding additional medical therapy. On the left, illustrates the risk of death at 1 year in patients who had symptomatic heart failure prior to the use of any of the modern therapies I mentioned, ACE inhibitors or beta blockers, and it was about 15% risk of death at 1 year. And this would be relevant to patients with myocarditis who had damage to their heart to that degree following a viral injury. Following the institution of an ACE inhibitor and digoxin, an ACE inhibitor, to the previous therapy, survival at 1 year dropped to about 12.4. The risk of death at 1 year dropped to 12.4%. With the addition of beta blockers, that risk dropped to 7.8%. And today, with those therapies and an implantable defibrillator in eligible patients, the risk has been cut overall in about a third, by 2/3, down to 5.8%. So that's pretty much the state of the art in patients with acute dilated cardiomyopathy, likely due to myocarditis. In the most recent data, the likelihood of death or transplant at 1 year is about 4.5%. So where are we going from here? We're investigating novel therapies to improve this risk, and we're also looking at improved diagnostic tests. I'd like to give you a couple of examples. The first, here you can see our apheresis laboratory upstairs with my colleague Ed Bergstaller on the right in front of an immunoadsorption device. The machine on the left behind the two women separates plasma from solid blood components, and the machine in the middle, or a bit to the right, actually filters autoantibodies directed against heart tissue. You can see a close-up here of that machine, and this particular example, and there are more than one other type of machine like this, removes antibodies non-specifically. And we demonstrated in a study a number of years ago that you could improve heart function in patients who had evidence of autoantibody-mediated cardiomyopathy. And that's relevant because it's one of the variants of myocarditis. And I should say there are studies ongoing in Japan and in Europe investigating variants of this therapy. Another technique that we're actively investigating here is the use of mapping catheters. These are used in the practice of electrophysiology to find areas of arrhythmia, a scar, and to ablate using radiofrequency ablation energy. These pictures here are voltage maps of the inside of the ventricle, in this case the right ventricle, showing where the arrow is a region of scar, which was subsequently biopsied and found to have cardiac sarcoidosis. We use this technique both to guide bioptomes to regions of active inflammation, as well as to give therapy to ablate regions where you might it might cause sudden death. Here you can see the network of NIH-funded heart failure sites, including Mayo Clinic, where we are doing some of these studies. We also work closely with the Cleveland Clinic and other institutions on other relevant protocols. So with that overview, I'd like to take time to thank you again and remind anybody who's listening who might be interested in studying myocarditis or have friends or colleagues who are interested that we have grants that we give out every year, and the deadline for grant submissions is coming up on December 1st. Please spread the word. If there are any questions that I can't answer in the next 40 minutes or so on the telephone or by this chat system, please feel free to email me. Thanks. So now we go to questions, and I understand you can call in or you can also type them in. I'll see them in this little box here.
Ladies and gentlemen, if you've got a question, please use the chat feature located in the lower left corner of your screen. Also, participants on the phone lines, your lines are now open and interactive. Please go ahead.
Dr. Cooper, this is Candace, and I'm going to start out with a question about myocarditis in children. I think you had said that sudden death is usually the result of heart failure or an arrhythmia.
Yeah.
Was I correct in that?
Yes. Sudden death is usually an arrhythmia.
It's usually an arrhythmia. Okay.
You could have a massive pulmonary embolus, but that's pretty rare in myocarditis.
Okay.
It's common that you have either a very fast heart rate that is too fast to sustain blood pressure, or as in the EKG that I illustrated, I'll click on it here so you can see it again, where the ventricle simply stops beating. And maybe some electrical activity, but there's no contraction. And that is also an unfortunate but not unheard of consequence of acute myocarditis.
And so my follow-up question to that is that should a child come to an emergency room with, or a physician, but likely an emergency room, should an EKG always be done, an EKG and an echo, to rule out at least the first step of myocarditis?
Right. It's hard to say always, Candace, because
yes.
Viral infections which can lead to myocarditis are very common.
Yes.
And only a very small percentage of them actually cause measurable damage to the heart.
Sure.
So the first triage step is visiting a physician, and that physician generally should listen to the heart and lungs and look for signs and symptoms of heart failure or arrhythmias. And then at that point, based on the examination, proceed to an EKG and echocardiogram based on the results of the first triage. I think it wouldn't be appropriate to recommend that every child with a viral illness get an echo and EKG.
Okay.
That wouldn't, because there'd be thousands and thousands of people screened for only a few cases.
Okay, thank you.
And I can say, for everyone listening, the terrible situation here is that in sudden death, there's almost always no warning. Some people may have a viral illness and then say they're going to go out and run a marathon. That's not all that common, but when it does happen and you have a chance to prevent the sudden death, and I'd say that what I recommend to healthy people is if you get a viral illness, it's best to rest. Avoid aerobic exercise for several days, at least until you feel better, and then go back to your usual exercise routines. That's probably safer than going out and exercising when you might have myocarditis. I don't know you need, but Candace, again, no specific evaluation with an echo or EKG is necessary unless you develop heart symptoms.
Okay. I was just trying to think of some questions that our participants might want to have answered.
I think another question people might have is, in acute myocarditis, not uncommonly, there's a decrease in heart pump function, and the ejection fraction, which is the number we use to reflect that function, is often diminished substantially, well within the range where you would place a defibrillator. But the current guideline recommendations and our own data, which have yet to be published, suggest that it's safe to wait 6 months to put in a defibrillator, and during that 6 months to allow the heart to heal following acute myocarditis, to give appropriate heart failure medications, and then re-measure the ejection fraction. And indeed, about 2/3 of people who recover from acute myocarditis don't need to have a defibrillator. So 6 months is the time window unless somebody presents with sudden death. I'd say, for most people listening, if nobody's called in with a question yet, that the biggest obstacle to preventing the consequence of the disease is recognizing it. And having people understand that a small number of people, but a clinically meaningful number, will develop inflammation in the heart following common viral infections, and to let physicians know that you should screen more intensively once you suspect cardiac injury is very important. It's the awareness part that I think is the biggest obstacle.
You have a question in the chat box, Dr. Cooper, from...
Yep, and I'll just read it because I'm not sure who can see it and who can't. It says, thank you for your very informative presentation. I'm curious if there are known genetic factors that predispose an individual to viral myocarditis. And that's an outstanding question. And at this point, we do not have any genomic studies. And the reason we don't have genomic studies is because you need generally multiple affected family members within a single pedigree, and we don't have that in people with myocarditis, with rare, very, very rare exceptions. And or you need a very large population-based study or with hundreds or even thousands of people, and it's very hard to gather that many samples of DNA with appropriate consent forms. The databases do exist in Europe to do that kind of study, and there are proposed protocols to look for genetic predispositions using very large cohorts primarily that I know of from Germany. We do not have that much data. We don't have those databases in the U.S. at present. So, Brian, the short answer is we don't have an answer, but because this disease is very genetic background dependent in mice and in rats, I think it's very likely that there will be strong genetic predispositions. The second question is from Samantha Boston. If you have had myocarditis, are you at greater risk for having a future virus attack the heart in the same manner? Does the damage done to the heart cause greater susceptibility for another virus? Outstanding question. This question does not have a definitive answer yet, so I'll give you my opinion in the absence of published data, and that is that I think structural abnormalities in the heart do put you at a small elevated increased risk of autoimmunity and recurrent infection. There's certainly a small number of people who get recurrent myopericarditis, which are chest pain syndromes associated with inflammation of the heart and the lining of the heart, the pericardium. And this can recur again and again over time, sometimes with an obvious virus predisposing it, and sometimes just as an unclear consequence of normal life. And so, although the data don't exist right now to document this, there are data, by the way, that suggest that children with myocarditis after a heart transplantation have a higher risk of rejection, suggesting that they have a predisposition to that form of autoimmunity. So my opinion is yes to both your questions, but there are no published data. And until we get another question, I'll just go on the same theme, Samantha. You don't actually have to have another virus attack the heart to cause direct viral injury. Can you imagine? You can imagine a circumstance where you just get a heightened immune reaction against, say, a bacteria or against a vaccine, and that in the context of previous injury, the memory T cells and cause a reactivation of the heart autoimmunity, although the stimulus for the more general immune reaction was not your heart. So I don't know that you actually need the virus to damage the heart again. It could be the heart could be an innocent bystander the second time. No, this question for those, again, I don't know if you can see it. The question is, should people with a previous episode of myocarditis avoid flu shots? No, flu shots have a really low level of alum and are not that immunogenic and are very, very safe. And I do recommend that people with myocarditis have flu shots, especially if they have persistent left ventricular dysfunction. So in the case of flu shots, no. There are other vaccines like the smallpox vaccine, which is extremely immunogenic and which does have a rate of about 1 in 200 of asymptomatic rises in troponin following vaccination. So there are some vaccines like that one that I probably would avoid if you've had previous myocarditis, but not flu shots. And by the way, all the common vaccines are very safe, including influenza and pneumococcus. If you are on any immunosuppressant drugs, you would want to avoid live vaccines like the flu version of the flu vaccine, which is given by nasal inhalation. But that's only relevant to people with immunodeficiencies or immunosuppression. So really, this is really the state of the art. I'll just mention a few areas of research waiting for another question, and that they are in terms of the first level of research is really just education, and the Myocarditis Foundation is very active. We have pamphlets for professionals and for patients on myocarditis and pediatric myocarditis, which we send proactively to pediatricians, for example, as well as our website, and we also promote education through conferences. And a second the area of more formal research is diagnosis, and we're working on better imaging tests, non-invasive imaging, as well as serum biomarkers to help predict people at risk of developing myocarditis. I think that the genetics will become interesting, but unfortunately it'll be very complicated, and I don't think there'll ever be genetic testing for myocarditis. It will, at least unless there's a huge change in the epidemiology of the disease. But we do need better non-invasive tests because the vast majority of the world does not have access to biopsies. There are no bioptomes in many entire countries, in Africa and Asia. And so we do need to have cheaper, more accurate non-invasive diagnostic tests. And then for therapy, I think more chronic myocarditis may respond to immunosuppression, and that's an area of active research. So we have another question from Brian Fishman. Are an EKG and echo sufficient to rule out existing heart damage from a viral episode in a patient that experiences sporadic sharp chest discomfort? Good question. The EKG is relatively nonspecific with and insensitive for myocarditis, with 50% of patients who have myocarditis would have non-diagnostic changes on an EKG. And an echo using standard assessments of systolic function is also fairly insensitive. My test of choice non-invasively is a cardiac MRI because it can give better tissue characterization, and I believe that it's probably more specific and more sensitive when performed with the proper sequences and the proper analysis. I think there are pretty good data to support that. However, it's worth saying that there are novel echo techniques, for example, strain imaging, which may be better, which are probably better than standard imaging for the diagnosis of myocarditis. So it's a changing target, but as of today, the answer to your question, Brian, with clinically available tools, my test of choice would be a cardiac MRI.
Dr. Cooper, are cardiac MRIs available more, are they more available in hospitals as opposed to biopsies and bioptomes?
Yes. Yeah.
More widely?
There are a lot more MRIs than bioptomes at most places, but most importantly, it's non-invasive.
Yeah.
The risk of a right ventricular biopsy in North America is about a 1 in 1,000 chance of death and a 1 in 250 chance of perforation of the right ventricle on average. Now, I think that risk is lower with different types of bioptomes that are available in Europe, but those are not clinically available here. So, given that risk and the risk of an MRI is essentially zero in somebody with normal renal function, I think that the MRI is a safer choice and a lot more available. The trouble with the MRI is that the proper sequences are not always done, and they are not always read systematically. And that's the challenge, that to do it well, you need post-processing software, which is not always available with the MRI packages.
So it's not just a question of who's reading it.
No, it involves not just reading it. You need to do quantitative analysis of the images, and the images do need to be performed in the proper sequence and then taken together. It's a fairly time-consuming process to do it correctly, but not inordinate. But it's not like a standard cardiac MRI. You need to do specific sequences to look for edema and scar tissue.
So how would an individual know whether or not the hospital that they were going to have this test done had the capability to make this diagnostic for myocarditis? How would a person know that?
That would be really hard. I don't know that a layperson would know if that were possible. You could always refer to our 2009 paper, which I'm happy to email anyone. And it's in the Journal of the American College of Cardiology, and it goes over in about 30 pages of fine text how to do a cardiac MRI for myocarditis. And that would, if you were very proactive and you happen to have that, you could take that and say, this is the sequence I'm looking for, can you do it? I think the major medical centers, Massachusetts General Hospital, Johns Hopkins, Mayo, would be able to do that routinely. The NIH would be able to do it. I think it would be unlikely in a small hospital, but not impossible.
Do we have any more questions from our audience?
Well, if not, my email is there if you need to send me an email, and I'm glad you all participated. Thank you very much for dialing in.
On behalf of all of us at the Myocarditis Foundation, we're grateful for you taking the time to participate with Dr. Cooper in this webinar, and our next webinar will be in December, I think, and it will be on grief, coping with grief in the holidays, and there'll be more coming out about that in the next couple of weeks. Thank you, everyone, for participating. I appreciate it.
Ladies and gentlemen, that does conclude the conference call for today. We thank you for your participation and ask that you please disconnect your line. Have a great day, everyone.